Look forward to sharing some of the work that I have been able to do with the help of my collaborators and co-investigators uh, in the area of disparities and health services research. In addition to serving as the Vice Chair for Research, I also have the privilege of serving as the co-director for the Behavioral Science and Analytics for the NORC, and also lead the Data Coordinating Center for National Center on Health, Physical Activity, and Disability. I share that because a lot of work that I have done is really because of the ideas and the interactions I had with some wonderful colleagues. I can't name everybody here, but Andrea Charrington, Jim Rimmer, Garrett Dutton, Zoe Young, a lot of people have worked to build the projects that we have today, and definitely benefited from a lot of centers that we have on campus. So to the students who are here today, I would really encourage to attend and align yourself, participate in these centers, because I learned a lot as being part of a North pre-doc. And that sort of helped shape my career beyond biostatistician and thinking more about what interventions could be developed further. So this is acknowledgements. We are also working with partners, University of Mississippi Medical Center, Cooper Green, and then Pack Health, which was acquired by Quest Diagnostics. Few disclosures. These studies are funded by NIH, CDC, PCORI, and actually the CDC one I won't be covering today because I won't have time, but the ones I will be covering would be NIH and PCORI, and then some of the consulting work I do as part of my role. So in my role within the family medicine and family and community medicine, and my thought process around health services and outcomes, I've sort of aligned the research aims, the research process to a research strategy around the quintuple aim. And this is sort of a modification of the quadruple aim, where the focus is to improve patient experience, population health, reduce healthcare cost, and improve provider experience. Along with, and the fifth one is achieving health equity. And so whenever I think about projects, what excites me is like, how does these projects align with the quintuple aim? Which aspect of the research study is going to help with population health, patient experience, even provider experience, and almost achieving health equity. And the reason is we are in Deep South. We have one of the highest cardiovascular rates in the nation. I think all of you in public health know that when it comes to obesity, diabetes, and hypertension, we are one of the worst in terms of the statistics. There are racial disparities that are very pronounced. Probably Mississippi is the only state that is worse than us, maybe Louisiana as well. But you can see from some of these data that when compared to the overall US population, we are doing far worse in all of these cardiometabolic conditions, and the racial disparities are even more pronounced within that. One area that increasingly I have focused on and work towards is understanding the suboptimal social determinants of health. And almost 40–50% of health disparities are attributable to this. Alabama has one of the highest poverty rates. And when you think about diffusing intervention or developing something sustainable to really influence change, then it really addressing these social determinants of health becomes a critical part of it. And it's important because even from a state level, when you think about what UAB health system can do, I think it's fairly limited in the sense of, unless we have partnerships, unless we address these social determinants of health, it's going to be very difficult to really improve the health of our population, of our state, of our community. Again, when you think about people living in poverty and uninsured status, the racial disparities within that are also very apparent. And those things motivate me. I think this is the why part. As I have developed skills over time, I feel like this is a way to even contribute back to research, to pragmatic studies that could be generating knowledge or diffusing things in the communities to really help our community. So I would submit that to develop sustainable interventions and mitigate disparities, we need some of these aspects. I don't want to make any claim that these are the only things, but like thinking about how we design studies in a creative and pragmatic way that can develop, that can generate knowledge, effectiveness, real world setting knowledge. It could also be implementation science studies that where we are looking at diffusing effective implementation, effective strategies or interventions. I think rigor in research, design, analysis, and interpretation is often sort of overlooked. And I'll give you an example of that at the very end, but this is important because if we are not rigorous about what we design and how we implement that, it's also going to lead to some sort of opportunity cost. So we are proposing things to diffuse in the communities that really don't work and sort of investing resources in those areas. Identifying interventions and strategies that really address social determinants of health. I think I mentioned about that. How do we incorporate preferences of community and interested parties? So there are methods such as discrete choice experiment. There are other preference-based approaches to understand willingness to pay, willingness to trade, which can be further sort of leveraged to understand what interventions would be have higher reach, better adoption and impact. Definitely leveraging AI and ML, artificial intelligence and machine learning to either develop interventions, data collection in a very decentralized way. And I would say the last two would be thinking about health and cost outcomes modeling to understand what would the intervention, if this is the effect size, if these are the benefits of the intervention, how would, at the population level, how would this reduce cost or improve the health of the population? And there are some simulation-based approaches that could also be used for that. The most importantly, I think I firmly believe that for us to be able to develop and develop sustainable interventions and then diffuse them, implement them, we need partnerships with community organizations. And you will see that in some of the projects I will be presenting today, we have a community organization partnering with us in helping us either with the intervention or some aspect of the study. So when I think about pragmatic study design, today I'll focus on between these, I'm just going to really focus on the first bullet point and probably have a slide or two about the rigor part to really highlight one area where there is really a need to focus on the rigor, is that what does pragmatic study design principles mean to me? For me, it means that, is the study being conducted in a real world setting? Are the inclusion-exclusion criteria for the study broad enough that we can generalize the findings? How are the outcomes relevant to practice and policymakers? And then the data collection needs to be such that it is, not burdensome to the clinics or to the participants, or so it has to be something that could be done in a somewhat burdenless way. So, and that's really hard because as researchers, we try to collect as much data as we want in any given study. How do you really prioritize those assessments becomes pretty important discussion. The Precis tool is a really good way to look at this aspect that, there are, when we think about pragmatic study, we may think about like this is a pragmatic study or not pragmatic study. It's really comes down to the continuum, where you are on the continuum, and the outer you are towards the circumference, then you are really more pragmatic. You are trying to design studies that are really that could be implemented somewhat in a real world setting without much disruption. I see that I've come to recognize that more now, especially with working with primary care practices where there's a lot of interest in doing interventions over there. They don't have time to really implement those interventions, and how do we really make the research integrate within practice becomes, this becomes really an important point of discussion. So from a sustainability point of view, one framework that I have focused on, and we are working with several collaborators, is this multi-phase optimization strategy. I think the core has done some really good workshops around it. Linda Collins, who is a phenomenal speaker, she I think visited here or presented. So I would really encourage you all to read her papers. Bonnie Springs has done some work in this area and was a mock speaker. But broadly speaking, this is a framework where there are three phases: the preparation phase, optimization phase, and then the evaluation phase. You can think about the preparation phase as the phase where we are trying to identify intervention components. So when we think about an intervention, it has generally we can divide that into a couple of components. So we are looking at different intervention components that could, when brought together, be developed as a intervention strategy. And the preparation phase is really the framework or the phase where we focus on identifying those intervention components. It's also where we would want to do any sort of pilot work, feasibility work. There are in some of the optimization designs, there are optimization criteria required, and I'll share a little bit more as we progress. But that preparatory phase is what this preparation phase is all about. The optimization phase is then focused on building an optimized intervention based on the intervention components that are identified through the preparation phase. And then within that optimization phase, there are several designs. So factorial experiment, fractional factorial experiment, the smart trial design. I'll give you a few examples of that. And then there is also just-in-time adaptive intervention. The idea being that this is a very resource-friendly way of testing which intervention components should be utilized to develop an intervention strategy. Because in a typical randomized controlled trial, we will otherwise require multiple RCTs to test these. So when you do a factorial experiment, we are able to look at the effectiveness of an intervention component in a very resource-friendly way. And the framework works in a way that you can identify then one or two strategies that are sort of competing against each other from an optimization point of view. And then the evaluation phase is all about doing a comparative effectiveness research of two intervention strategies that may be, fairly equal in terms of optimized intervention, or they may be a pretty good competitors. And the whole idea is around being resource management friendly, it's very sample size from a sample size and implementation point of view, not requiring several randomized controlled trials. At the same time, looking at this framework from a continuous optimization phase. So once your evaluation phase, your RCT is done of comparative effectiveness research, that may give you information further again to sort of refine your strategy to go back into optimization. So with that in mind, I'll introduce you to the first project, which is we have just launched. It's part of the Forge Ahead Center that Andrea Charrington, Garrett Dutton, and Orlando Gutierrez are the center PIs and leading the Freedom Project. Again, we have partners, Pack Health, Cooper Green, UMMC, to implement, to work on this project. And just a note on the center, it's about focused on diabetes, obesity, and hypertension, and again, focused to achieve health equity around it. The way this project came about was as we got an announcement of the P50 being, this is due, I don't know, like 8 weeks or 12. It was some very short period of time, and we were discussing about what could be a potentially good project to build for this one. And I proposed to Andrea. I still remember I was actually preparing tea, and I think she was cooking. And I said, well, why don't we do a project where something where health system is already implementing intervention strategy. Let's try to see, can we build something that is optimized? And so the goal was to really leverage what has already been done by the either the health system or our community partners, and to build a project and understand, can we develop a multi-level, scalable, sustainable diabetes management project, diabetes management intervention that targets relevant social determinants of health. And so this is a multi-level precision public health project where we are focusing on health behaviors and personal environment of individuals, focusing again on patient care, team communication, health services, and also partnering with community organizations. And it is much more in the spectrum of managing diabetes. These are people with type 2 diabetes and other cardiorenal conditions that we are focused on. So what are the objectives and what are the intervention components? So the intervention components are digital health coaching. That digital health coaching is being delivered by Pack Health. Pack Health is a company that really started this a couple of years ago, and through some collaboration, I knew that they were building this area very robustly. Their coaching is audio-based. So this is a digital health coaching is one intervention component. Food box delivery, that is to address the food insecurity part. And then remote patient monitoring, which is delivered by UAB Health System, Eric Wallace team. And then UMMC has its own remote patient monitoring. And the questions were, which of these combinations are clinically effective when it comes to reduction in hemoglobin A1C, identifying the optimal combination based on cost effectiveness, and the optimization criteria for this was the incremental cost effectiveness ratio. And the third aim was around implementation science, was around identifying the contextual factors that affect implementation of different intervention components. As you can see from this, it's a factorial experiment. Patients will get randomized, or participants will get randomized across 8 different combinations. All of them will get diabetes education, will be referred to a certified diabetes educator, but then some will get all 3 combinations, all 3 components, some will get one of these. And the idea being, we want to learn which combination of these intervention components is really effective and then cost effective. And so it's a pragmatic type 1 hybrid optimization implementation trial. It's not an effectiveness trial, it's an optimization trial. So that's the difference is that we are going to this factorial experiment test whether digital health coaching, food box delivery, RPM as main effects are effective, and then also look at some of the interactions. So digital health coaching is addressing individual, interpersonal, and organizational level in terms of social determinants of health. So transportation, health literacy, health services access, and quality of care. So these are health coaches that are not healthcare professionals, but they are trained through a health and wellness certification, and they offer audio calls to to their participants, and also help with navigating access to care when needed. The RPM is a very organizational level healthcare system based. So again, remote patient monitoring for diabetes uh, allows us to track their blood glucose and provide feedback to those who have certain issues come up. So again, these three subdomains are mapped for RPM and digital health coaching. And then the food box delivery is also being delivered through Pack Health, but it's McLean Global that is actually providing food boxes, which addresses the food insecurity aspect. And this was something, again, as I was working during COVID, I recognized that some of the payers had actually reached out to Pack Health and others about addressing food insecurity, and they had already piloted these programs. So these are data really from the Pack Health's health coaching itself, but there is also now systematic review and meta-analysis done that presents health coaching as a way to effectively reduce hemoglobin A1C. And you can see that this is especially true for patients with higher risk, higher baseline levels of hemoglobin A1C actually see more benefit out of it. And so we were also looking at patients who would be, or participants who would be people who would be having uncontrolled type 2 diabetes. And so part of the process and this was something we laid out in the grant itself. So in a way, the grant was the preparatory phase because grant writing that we were trying to figure out which components. And family medicine had also piloted this with Pack Health while referring their patients to health coaching. So there's quite a bit of literature coming out around health coaching served by non-healthcare professionals to be helping in hemoglobin A1C, so diabetes, obesity, and hypertension related management. And so the health coaching piece for us here is, I need to just be mindful of my time. Health coaching piece over here involves 12 weeks of outbound calls that participants receive, and there's a set module around it. And then from weeks 13 to 24, there are inbound calls, digital communication that is done. Goal setting is one of the most important parts in this piece. So and this is all phone based, no video based. Phone based, really to ensure that there is access, because when you start doing video based, we again start getting into access issues around videos. The RPM data, again, there is just some recent work in meta-analysis done where there's evidence showing RPM to be improving in managing or helping in managing hemoglobin A1C. And these are data from UMMC. So UMMC RPM program is actually older than what we have over here. And so we had some of that data as well, and some of the published work around this. So the preparation phase for us was, is this being already implemented? Has this been shown to improve outcomes? And so that's why we chose RPM and health coaching. For RPM, it's interesting that two health systems, two different ways of implementing RPM. So we had to harmonize the protocol a bit, but we still wanted to be pragmatic. So we did not want them to change things completely. So we were able to make some things align around the alert parameters. The way it works is that participants, people who get assigned to a combination that is RPM will be regularly checking their blood glucose 3 times a day. And if a certain alert comes about, then the RPM team first reaches out. But then it also reaches out to primary care if there is some insulin titration that needs to be done. So that's really the RPM piece. And in a way, we will also learn about the two different implementations happening at UMMC and UAB. UAB is decentralized, but the RPM team does involve primary care providers. UMMC team is much more centralized. The RPM team does all the changes in insulin and medications themselves. I think there is some implementation issues that are sort of nested within this that we would be able to also study while as we implement this trial. This was the most interesting one, and I think this was the one which I felt that we had at the time not enough evidence. There was evidence of feasibility. There was not necessarily evidence of like outcomes improving. And I think now there is some more data out there that shows food box delivery improves food insecurity, reduces diabetes distress, and helps in reduction in hemoglobin A1C. And then African American adults with lowest food insecurity scores benefited the most. So basically, the people who had high level of food insecurity benefited the most with this program. And so for us in this project, we are going, again, these are implementations that are sort of happening anyway. So we were trying to make minimal changes to what was being done. Bi-weekly food box deliveries over the course of 6 months. These would be shelf stable that adhere to ADA nutrition guidelines. And the value is up to $60. And this is again interesting because when we wrote this grant and got funded, we never thought about inflation. And now we have to think about those aspects as we are implementing. So the food boxes, we'll be accounting for some of that while we are doing the analysis as well. Eligibility criteria, trying to keep it broad. Again, a lot of discussion around whether insulin should be a criteria or not. Some of the criteria, again, from a CVD, CKD point of view, was to address people with multiple chronic conditions, uncontrolled diabetes. And then a key part is participants who are residing in area deprivation index, or high or moderate area deprivation index. This is a brief overview of like what we plan to collect. There's a lot over here, but again, to focus on the pragmatic part, we tried our best to minimize what we are going to collect and how we are going to collect this information, trying to collect it as much from the EMR as we can, rather than ask patients or participants to give more information. And there is a research coordinating center. Actually, Paul Mutner is also part of the center grant. And, because it's a health equity grant, there is also, and part of the center, we had to collect all these common data elements and all the tension between how much we should be asking and what we can do after we ask. Like if we ask about some questions, but we are not able to offer help, what does that mean? I think those discussions have played out and sort of moved forward. So this is an ongoing study. We have started recruiting at all our sites. And a very good example of a factorial experiment, part of the MOST framework, which uses all the intervention components are something that are being implemented in the real world and have some level of feasibility or evidence about outcomes. The other factorial experiment that we have ongoing as part of this to again address disparities is our Godard project. Uh, it is a work that I'm ongoing with my good colleague and friend Mohan from Health Services Administration. And the idea over here is to uh, really look at feasibility of implementing in a most trial. And there are two components to it. One is what we call as a technology-based component, and one is resource-based component. The technology-based component is the coaching component, where we would be providing participants, people with either human coaching or AI-based coaching. And then the rewards component is based on gamification, resource-based. So should the rewards be fixed, or should the rewards be adaptive? And everybody will have access to like this automated behavior monitoring system, which will leverage the AI-based technology. So there is a nutritionics app that we are using to really use NLP to learn and track food and nutrition and exercise related content. So the goal is, again, this is a 2x2 factorial. Participants get randomized between coaching and rewards. And I call this as most preparatory phase because we are actually piloting this. This has not been implemented before. We really need to look at the feasibility of this. Again, how implementing this API from a IVR call. So we are going to use integrated voice response to collect data, and that data will be, the answers provided through that then would be used through this app, through this API to convert into behavioral monitoring system, which then either the human coach or the AI-based coach can provide feedback to the participant. So it's pretty, it requires assessing the feasibility of the whole process around it. And so that's really what the objectives for this particular project are. And this one will start recruitment in around May. The other optimization trials, and I wanted to give you a flavor of that, is around my colleague and friend Drew Sayer, who along with me and Gareth has implemented this smart lifestyle project with the really goal of integrating this within the community or community medicine, family medicine. And the idea is participants get randomized to diet counseling or exercise counseling. And at 8 weeks, there is a quickie score, an insulin index score, that is used to understand whether somebody is a responder or a non-responder. So that's like a tailoring variable. So when you think about a smart trial, one of the aspects in the preparatory phase one needs to do is understand which tailoring variable should we be using. So participants get randomized in these two arms at first level. And if for non-responders, then they get further re-randomized to either a weight loss based nutrition counseling or a medication based approach. And so the first level diet counseling is more at a macronutrient level. It's a weight neutral approach. And at the second level, it's a very intensive weight loss approach. And the idea here is to really develop an adaptive intervention that we can assess at 8 weeks. We can assess whether there has been enough change in the insulin score. If yes, then they continue with their existing intervention. If not, then they get added to another intervention component. It could be either adding or it could be changing. So again, this is another way of looking at how we can build use intervention components to build optimized adaptive designs, adaptive interventions for people. And like, it depends on the question we are asking. And this is often the fun part we go through for like, should it be a smart design? Should it be a factorial experiment? I could frame this as a full factorial experiment. I could frame this as a smart design. But the why part, like what are we trying to achieve here? It becomes extremely important. And I think Bonnie Springs in her talk has also mentioned this, and I wanted to sort of summarize it over here, that a factorial experiment from an optimization point of view is helping you develop an intervention package on an average that works for the population. The smart trial, on the other hand, is trying to develop an optimized intervention package that accounts for between person heterogeneity. If you think about, for some people, they were non-responders, they need to be transitioned to another intervention strategy. And that's the between person heterogeneity. And then there is also the just-in-time adaptive intervention, which we haven't really started yet. We are discussing about the project around it, but that accounts for the within person variation. Because that accounts for like, okay, I went to a grocery store and was being tracked across what my behaviors were, and I will have an adaptive intervention component that will nudge me to do something, move towards adhering to my sort of healthy behavior protocol. From an optimization phase, all these are sort of very interesting. From a preparatory phase, factorial experiment requires like looking at optimization criteria. And a lot of work can be done using secondary data to look at optimization criteria. Assessing preferences, again, one of the things about the current status of like the smart trials is that oftentimes we are looking at a single tailoring variable, but you could really have, predictive algorithms develop composite tailoring variable. How you implement that, and is a different thing. But I think there is a way to implement it, and that's one area we want to move forward with. And then again, the preparatory phase becomes extremely important to understand the feasibility of what you are planning and proposing in the optimization phase. So on that note, I will switch gears and move to a study that we have recently wrapped up. And I think this sort of actually started my journey as a health services person. A PCORI announcement was out, and I spoke with Jim Rimmer about like, we need to work on this. This is a pretty interesting, announcement focused on people with multiple sclerosis. And we had met with Dr. Emily Reiser and Tracy, who are our sort of community partners. They have a clinic in Homewood and a lot of advocacy work that they do, where they provide specialized care for people with multiple sclerosis. And people used to drive from Mississippi and rest of the Alabama to really have access to those needs. So what we proposed is, well, can we propose to really see whether this intervention can be compared both from a in-person rehab versus, or in-person exercise versus an asynchronous exercise provider. So that's really what, and it really started at Pancake House, which unfortunately I think is closed now. No, it's back. Okay, awesome. So, but that's where our first meeting was, and this is sort of the stakeholder panel that got convened because of the awesome connections they had, Tracy and Dr. Reiser. So again, this is a pragmatic cluster randomized trial focused on comparing whether on-site care, on-site rehab exercise care for people with multiple sclerosis versus an asynchronous telecare coupled with integrated voice response. And I think that was really a contribution that Dori Pekmezi, a faculty from School of Public Health and a fantastic collaborator. She sort of introduced that back in 2016 for us, and she was already doing some of the work in that area. So we call it direct cam and telecam. There are some neuro rehabilitation exercises along with Pilates and yoga. The focus was to really see whether can we reduce, the primary outcomes were fatigue, quality of life, pain, and physical activity. Most of the trials back then were focused on 3 months outcomes. So from a PCORI point of view, we were also focusing on sustained effect of a 12-month outcome. And the home-based preloaded tablets with IVR call, that that intervention was, and you can almost break it up, like, there are two components again over here. One is the tablet piece, and then one is the IVR piece. Back then, we just combined all of it and proposed a comparative effectiveness trial. But it was really to address the disparities in the care, because we did not want to depend on internet access, or definitely not high-speed internet access. So these were, the telecam group would receive home-based exercises through preloaded tablets, and then regular check-ins through IVR calls. We randomized 40 outpatient clinics and had a partnership with Rare Physical Therapy, which had several sites across the Southeast, and had a very broad inclusion criteria. Physical activity guidelines, those who met the physical activity guidelines should not be included. That was sort of a mistake. It was not part of the original proposal, but was really advocated by some. But it really led to some interesting things about when you're having a cluster randomized trial, participants who want to get into the trial find out, that reporting such a score would exclude me from the trial. And I think it would, we just led to some very interesting scores that we have received for Codyne. So again, trying to keep the criteria as broad as possible is always very helpful. The assessments was done such that they were, really applicable in the physical therapy clinics, and could be done in a somewhat speedy way. I think there were some challenges in terms of self-reported outcomes, but these were basically what we really collected from our participants. SF36 was probably the longest one, and I would change that to something shorter now if I had to do it again. Several partnerships. We worked with Tanner Center, National Multiple Sclerosis Society. And the reason we did this cluster randomized trial, I guess that was most important, was that at the time, at least in certain areas, there was active support groups. And so if we are giving home-based preloaded tablets, then that could lead to contamination, intervention contamination, that could really, you could see a scenario where a direct cam participant and a telecam participant in the same support group could end up having, resources. And so that was one of the reasons why we went for a cluster RCT. This was an effectiveness trial. Just lots of PCORI meetings and celebrations. We were on the monthly calls every time, and I almost felt like we were trying to figure out how do we recruit, from where do we recruit, and what we met our recruitment goals. Some things that I thought we did really well in terms of planning. So as we were trying, it was one of the largest trials, people with MS, definitely in Deep South, but I would say even nationally when it comes to this topic. We also wanted to study some practice-related things around, do we really need to assess both dynamic gait index and both balance scale? And this was an important question from a provider experience point of view, like how many assessments do we need to do in a clinic? And so we were able to identify sites that had the same at same steps, the same tool to measure dynamic gait index, and were able to really come up with some findings that would also inform practice around, well, if you are measuring work balance scale, you probably don't need to also do a dynamic gait index assessment. I think there was some planning around that. We are also working on some clinically meaningful, important difference papers using the data we have from a secondary data analysis point of view. Well, everybody, we all ran into some challenging times during COVID, and we were able to secure a supplement to really, using a quasi-experimental design, compare the direct cam, which was on site, with a synchronous tele direct cam. So a telecam was asynchronous. We wanted to see, whether we can look at from a synchronous point of view. And so we did a non-inferiority comparison by developing a study within that, and we have sort of wrapped up that as well. Last couple of thoughts around this. So cluster randomized trial, it's one of the most common things we see that when it comes to rigor, people are either not powering themselves up enough for a cluster RCT, or not accounting for the clusters when analyzing. There are also some, this is my experience, when we actually implement it, there's the one thing about having a design on paper, and then the reality of implementing that, I think leads to some interesting decisions we have to wrestle with. And so for the students, I would really encourage you all to sort of look at the rigor part of how do you, there are some papers that we have published around it in rigor. Then there's some other interesting work also out there in around just some common errors that are done when designing or analyzing studies, because it does then lead you to a different path. So that's just one. From a cluster RCT, it's very common to see some errors, to the point that as an associate editor, we had to then work to develop a guide about how do even we as reviewers look at cluster RCTs when evaluating. So just a brief summary. Today I spoke a lot about randomized design, but there is also a lot of role for non-randomized design. So the team's COVID enhancement was a quasi-experimental. The level of randomization depends on what your real-world setting is. If it's an implementation science study, then maybe likely you will need to make a cluster-level randomization. But thinking about those things are important. The choice of interventions, outcomes is important from a pragmatic point of view. From a sustainability point of view, thinking about adaptive designs, optimization designs is important. And then there is an array of effectiveness implementation hybrid designs that one can also look at when planning studies. This is sort of my overarching theme. I strongly believe that for us to get to that quadruple aim plus health equity, we need to have a learning health system view. We need to have community partnerships. Public health plays a very key role in this. And, we need to be rigorous but creative in terms of how we develop these pragmatic designs to mitigate disparities, especially in Deep South, where we have a lot of those and we are very under-resourced. Many thanks for your time. My kids and my wife, and then no, there is a spring break. So for those for kids, so those who are able to come, I just added this slide because I got reminded, I have a presentation during its spring break time. That's